Thank you, Frank. And once again, it's a pleasure to be doing this with you. Some of you may not realize, but Senator Antenori and I've been working on a project to do a Medicaid reform for the state of Arizona based upon a model developed by the past president of the AAPS in New Jersey. And it is something that we have to elect him this season to be able to carry this forward in the state this year. Last year it was blocked by some of the insurance lobbies and other big special interest groups. But if we can succeed, get him back to the state legislature and move this project forward, it can save Arizona, we calculated, about $6 billion and provide better access to care for the poor as well. So one of many reasons that we want to see Senator Antenori back in the legislature this coming season, and one of many reasons that I'm spending time supporting his efforts by helping to educate people about some of the perils of Obamacare. And that has been the name that's been given in the public and in the press and the media on both sides of the aisle. But fundamentally, what I'd like to have you think about is that this really isn't about partisan politics. It's really about patients' lives. And it's really about who gets to decide your care when you're sick. You, your doctor, and your family? Or is it going to be anonymous third-party bureaucrats? And let me define that term, because the bureaucrats can be private insurance company bureaucrats, the HMO model, where clerks or people hired by the insurance company are telling your doctor what he or she can and cannot do, or the bureaucrats can be government, as in the VA or the Medicare people now that deny certain procedures or labs or whatever. And under the new rules that are coming and being written, we will have the Independent Payment Advisory Board, which is a group of 15 unelected, unaccountable, politically appointed bureaucrats that will decide what medical treatment is covered and what is not. And something most people do not realize, if Medicare doesn't reimburse it, you cannot today ask your doctor if you can pay cash to have what Medicare has denied. Your doctor is not allowed to let you pay more or pay out of pocket if he or she is a Medicare contracted physician. So that is the situation today. Under the new healthcare law, it's even more draconian. And if it's not reimbursed, it's not going to be allowed. And most people in the United States are not used to that. They're not used to having their freedom to make personal decisions taken away like that. So fundamentally, that's one reason I have spent years advocating for patient control over their decisions. It's why I resigned from all insurance contracts in 1986, 1 year after I started my private practice, because the insurance companies and the HMOs were telling me what I couldn't do for the patients who were in my office. And all physicians take an oath. The oath, correctly, the Oath of Hippocrates. And it's important that you understand that, because the Oath of Hippocrates has governed the practice of medicine for over 2,500 years. And it is the cornerstone and foundation upon which we practice our profession. And I'll have to say, for all of you in this room, do not use the term provider when you're talking with me, because as far as I'm concerned, that's somebody who sells their services on the street. And physicians who answer to their patients, who have taken an oath to serve their patients' best interest, are professionals. They're not providers. So when you use the jargon that demeans the professional commitment that your healthcare professionals, nurses and doctors and physical therapists and psychologists and everyone that you see for healthcare services are professional people who've worked very hard to do their best for you. And we need to be rethinking how we approach this. Your life is the most important asset that you have. Your health is actually your greatest wealth. Now, we're going to talk about the money impact and the tax impact and all of that. But I will submit to you that without your health, your money isn't going to do you a lot of good. And especially if you can't even use it to help your health be better. So it's extremely important that everybody understand that you tell your friends what you're learning by taking the time to come tonight, and that you share this information and you focus on electing people who fundamentally understand that we are talking about your life is at stake and your pocketbook indirectly as well affected, but your health is first and foremost your biggest wealth, your greatest wealth. Now, people have said, what about some of the treatment? And won't this ObamaCare or the Patient Protection and Affordable Care Act, probably one of the most misnamed pieces of legislation that I've ever seen, it's not protective of patients. In fact, it's the most intrusive of patients in terms of any legislation I've seen in my whole career. And it is certainly not affordable care. It's estimated to expand the deficit, and in order to pay for it, those that voted for the new healthcare law have stolen $716 billion from the Medicare budget for older people. So when you see the ads that say the Republicans or Paul Ryan are going to throw Granny off the cliff and decimate Medicare, ladies and gentlemen, they are trying to save it for the current retirees and offer new options in addition to traditional Medicare for people younger than 55. If we keep going the way we are going, as Mark Twain said, you may end up where you're going. And where we're going is off the cliff financially, because Medicare has already been decimated by the new healthcare law with the cuts that I've just talked about. And I was saying the initial data we had was $500 billion. The new CBO, Congressional Budget Office, has just come out last week with new estimates of what is being cut from Medicare, and it's $716 billion. If you think your Medicare that you're used to having is still in effect, come January 2013, it won't be. And 2014, and each year that these cuts go into effect. So that's fundamentally number one. Medicare, as we've known it, is gone with the passage of the new healthcare law. There are 2,700 pages in the last permutation of the bill. And for that 2,700 pages, over 13,000 pages of regulations have already been written, and they haven't even finished a third of the bill. Now, it's not humanly possible to keep up with all of those regulations. What does that mean for you? Well, I mentioned the Payment Advisory Board, the Independent Payment Advisory Board. Congress, they're not even accountable to Congress. They're not accountable to the judiciary. There is no appeal to their decisions. It's not like we do today where we can appeal insurance company provisions when a private insurance company denies a particular medicine or a procedure for one of my patients. Yes, it's a nuisance, but we get on the phone and we call, we give them more information, and we keep pushing until we get it approved. There's an appeal process, and all of you, I'm sure, have dealt with that. But under the new law, there is no appeal process to the decisions of the Independent Payment Advisory Board. And that's one of the really serious problems with that particular body. There's only a 2-week window in January of 2017 in which it can be removed or changed. So this was a pretty sneaky attack on physicians' decision-making and patients' decision-making. Now, let me give you some examples. The Independent Payment Advisory Board in the United States, to be implemented shortly, is comparable to what's called in England the National Institute of Clinical Excellence, or NICE. In 1998, NICE was sold to the British public as the board appointed by the government that would weed out the bad doctors and would get people the best practices and improved quality of care. By 2008, it was clear that the NICE board had become the rationing board for the national health system. I'll give you a couple of examples. They've cut back on prostate cancer screening. They've cut back on breast cancer screening. British women, and I have some people from England in my practice. I have lots of Canadians in my practice. And they screen women for between 50 and 70 only every 3 years. The fastest rising group of new breast cancer cases is women between 40 and 50. And those women tend to get more aggressive cancers. So if you don't start screening until age 50, you're going to miss the greatest risk group of women. So that's one example. In another example, they've cut back the new drugs for stomach, lung, breast, and prostate cancer treatment. They have cut back new drugs for multiple sclerosis, rheumatoid arthritis, and multiple myeloma. And if you have macular degeneration, anybody in here have that problem? Well, Lucentis is one of the new drugs. There are some others that we have that the British people do not get. In Britain, for a patient to be approved for Lucentis therapy for macular degeneration, they have to have already gone blind in one eye. They won't intervene and approve payment until someone is trying to save their last eye. You can get by with one. That is government rationing. That is going on today. Whether you hear the glories of the National Health Service on the Olympics or not, that is the reality. There was a study last year that showed that 148,000, give or take, patients went into British hospitals in 2008 malnourished. 10,000 more came out of the hospital malnourished. In 2010, the figure was even worse. 160,000 came out of the hospital malnourished. That's the status of government-run healthcare in one of the examples that's used so often. Canada, long waits for MRI scans. It can be months. It can be months before people are referred to cancer specialists. I have patients from Canada who've had to wait a year to get assigned a primary care doctor. I had one patient who brought her daughter to see me for things they couldn't get in Canada, and she said, "My father waited 18 months for his hip surgery, and by the time they approved it, he was so debilitated that he could never recover his ability to walk, and he was addicted to pain medication." So the answer, And you will see it in the documentary. We have some copies. AAPS is making those available to you as an educational service. Please listen to this hour-long documentary about the realities of the Canadian system and the interviews with patients, some of whom died before the film could even be completed, waiting for care. And then when you've watched it, share it with your friends at church or at home or in your community groups or your synagogue or any groups that you're part of. Share this so that people understand. Americans are not used to this. We've been independent. We've been able to think through and work with our healthcare professionals to make our decisions. That is not going to be the case. And another issue that has come up often is, well, Dr. Vliet, what about if we don't provide this insurance for everyone? What's going to happen to access? Ladies and gentlemen, access to care has never been the issue. The issue is about who's paying for it. Since 1986, since the beginning of my career, the federal law is that no hospital can turn someone away from an emergency room for inability to pay. So the patients get the care, and I've been a patient overseas, in fact, in a London emergency room, which is a pretty horrible experience. You want details on that, we'll talk about it later. I've also been in the Soviet Union during the Soviet days, and I've seen the condition of their hospitals. I've seen Italian hospitals. You would be blown away by some of the conditions in hospitals that are supposedly civilized countries. We're not used to that. Our patients, the poorest of the poor and those with no resources, get state-of-the-art care. I trained at Johns Hopkins. Inner city Baltimore patients had the best care in the world, whether they could pay for it or not. They came in our ER day in and day out, 24/7. And I never did tell my husband some of the things that we saw in the emergency room because it was pretty incredible in the kinds of things that were coming in and out of there. But they got state-of-the-art care, free. The taxpayers paid it. So one of the things that you have to understand, it's not about access to care. And I'm going to tell you tonight, and 3 or 4 years from now, if this goes forward, you can say, yeah, she warned me about that. Having insurance does not guarantee you access to care that is timely and tailored to what you need. If we are having 10,000 baby boomers retiring every day for the next 19 years, and we have a doctor shortage of 125,000 doctors by another decade from now, and if we're putting 30 million more people into the system with suddenly insurance and the idea that their care is free, do you think your access is going to be what it is today? When you can call up and get an appointment with your doctor pretty quickly, especially if you're really sick. We are putting more and more human lives into the system. We have 45% of physicians have been polled and said they are leaving medicine rather than be government slaves and dictated to by government bureaucrats what to do for patients. We have a shortage of doctors already, and we are putting more retirees and more people into the system. Do the math. It isn't going to work. You can have all the insurance policies in the world. If you can't get to a doctor, you are not going to get the care you need. And fundamentally, that is a huge part of the problem. In addition, Mayo Clinic just did a survey of over 7,288 doctors. 45.8% of them were so burned out in this survey that they were ready to give up. They are under siege by paperwork, which is only going to get worse under the increasing regulations, One doctor wrote a letter that just came out in the Wall Street Journal actually today, and he said, I've had to cut back my time 50% just to take care of administrative functions. 50%. What does that do to your patient care when you need it? And this is the kind of thing, I don't really care whether you're a Republican or a Democrat or a Libertarian or Green Party or the Moon Party. Really, if you're sick and you need care, your body does not care what political party you happen to have signed up for. And when you're sick, you want your health back, you want your life back. You don't want somebody standing in the way of your getting that. So I may be preaching to the choir because those of you that came tonight care enough about this subject to come out after work or after a busy day and come to an evening program. But I urge you to listen to the reality that we're facing and find in some of the material that I've written, the Canadian documentary, we have a CD for you of the program that Senator Antenori and I just did Sunday morning on the health insurance exchanges that the governor wants to implement in Arizona. I'm going to let him tell you about some of the problems with that, and I'm just going to sit here and say to you that health insurance exchanges are using a benign sounding word to lull you into a sense of, oh, this is a great thing. I'm going to have lots of things to choose from. Ladies and gentlemen, you are exchanging not something of equal value as we think of it. You're exchanging your freedom for more government control of your life. And it is through the government, federal or state, doesn't matter which exchange you're talking about, they both are state agencies deciding what types of insurance policies will be available for you to buy and what the coverages will be that determine whether or not you get the care you need. So you'll hear more about that in just a minute. We're going to have a whole hour for Q&A.
Okay.
So write your questions down. Both Senator Antenori and I are happy to take your questions. We had agreed I would do the first 30 minutes, he's going to do 30 minutes, and then we'll open it up to a free fall of questions, whatever you want to ask. Thank you, though, for thinking. So I really want you to think about the fact, I have been a patient. I've been a patient in a government-run program. I have worked in government. I've worked in VAs. I've worked in naval hospitals. I've worked in private hospitals, and I've worked in community hospitals. So I've had lots of experience in different types of healthcare settings, and I've also been a patient in different hospitals. I told you about the London experience. And I'm walking and functioning today, and I'm not a quadriplegic because I lived in the United States. I had a rapid MRI when I had a spinal cord compression in the cervical spine. And I got back up to my alma mater and had neurosurgery done by the chief of neurosurgery at Johns Hopkins. And he wasn't sure that all of the function would come back, but he said, we don't have a choice, we have to do it now. And a few more days and I would have spent the rest of my life in a wheelchair. So if anybody understands what it's like to be a vulnerable patient and to know how important it is to have timely care, as someone who's practicing in the field and has also lived that journey, I absolutely know how critical it is. So that's where my passion comes from. I'm a political independent and a medical independent, and I really care deeply that we preserve medical freedom for all of us and that we preserve life at both ends of the spectrum for the elderly. You hear a lot about abortion, But the elderly are going to be euthanized. We won't use that word, but that's what it'll be, when they are not readmitted for congestive heart failure, or when they are not approved for treatment. Well, you've lived long enough. That's what British patients are told. So life at both ends of the spectrum, we go to heroic efforts to save tiny little preemie babies that no other country in the world tries to save. That's one reason our longevity statistics don't look as good as some other countries that cook the books. Plus, we have a lot more homicides and a lot more automobile accidents that affect younger people and affect longevity. But I will stack our outcomes for cancer treatment, for heart disease, for neurosurgery, for orthopedic surgeries, for stroke treatment, all of that. I'll stack it up against anybody, anywhere in the world. And we also lead the world in innovation on cancer drugs, on innovation of new medical devices. 50% of the world's cancer drugs were launched in the United States over the last decade. You want to talk a couple of other quick statistics before I turn the program over to Senator Antenori? Let me just ask you, have any of you men had the misfortune of having prostate cancer? Okay, I know one has. Well, in the United States, men who are diagnosed with prostate cancer have a better than 90% 5-year survival. It's actually about 92%. In the UK, it's 51%. So where would you rather live and be diagnosed with prostate cancer? Here or there? For the women with breast cancer, if you look at stage 1 breast cancer, in the United States, the survival rate for 5 years is better than 90% again. If you look at all stages of breast cancer, our 5-year survival is 84% versus the UK, approximately 64%, depending upon how they report the statistics. So just on those two things alone, and of 16 different cancers, looking at the worldwide studies on survival, the United States has 5 of those 16 in which we have better than a 90% 5-year survival rate. Only one other country in the world has 1 of those 16 with a 5-year survival of better than 90%. And some of you that have heard me speak before know which it is. That's France with testicular cancer. So you might know that France would make sure that was one that did well. But we lead the world in medical innovation, in outcomes for serious illnesses and diseases, and in trauma care. We teach other countries management of trauma cases. So let's look at what's good, let's fix what's broken, and we'll talk about some ways to do that. And what's broken is the payment system. That we can fix. And we can do so without compromising patient liberty if we make changes through the electoral process that can reverse this tsunami of government control. And with that, I'm going to turn it over to Senator Antenori.
I'm going to kind of go into now on the economic impact and the tax impact that the federal health care law is going to have on everybody. It's no secret. I mean, it's pretty clear. There are 21 new taxes in that law. The Supreme Court has ruled that the federal government has the authority to tax people. That was the justification for the Roberts decision with regard to the constitutionality of the law. Although the people that advocated for the passage of the bill didn't call it a tax, they called it a penalty. But when it went to the court, it was a tax and not a penalty. So I don't know, is it a tax, is it a penalty? I'll tell you what it is. It's going to destroy an economy that is just beginning to come back and recover. Already, I don't know if you guys saw, there was a big headline that Papa John's Pizza had to raise the price of pizza 14 cents to start dealing with just the compliance cost of the Federal Health Care Act, not even all the other aspects when it kicks in 2015. In 2015, you'll probably see another significant increase. A lot of employers are making decisions right now as we speak on whether or not they're going to provide health coverage for their employees once the Federal Health Care Act goes into full effect in 2015. So what's that going to have as far as an impact on you? I'm going to give you a little history with Arizona itself, history in this state. pretty much nationally, 45 states now provide health care, indigent health care, for people that are at 75% of the federal poverty level or lower. Back in 2002, the state of Arizona put an initiative on the ballot that Governor Napolitano was pushing that basically expanded that to 100% of the federal poverty level. And she sold the initiative to the taxpayers, stating that it would not impact you financially because she was going to use the tobacco lawsuit settlement money that the state of Arizona had won as a result of the lawsuit that was filed against the tobacco manufacturers for the impact of treating all these cancer and respiratory patients in our hospitals. They gave us a settlement. And that money was going to go into an account that was then going to fund this expansion of the Medicaid, or access, as it's called in Arizona, the access population. At the time, we had about 400,000 people on access. Okay, this was just in 2002. The initiative passed, and in just 1 year, that number ballooned to 600,000 people. And then in 2 years, it was close to 800,000 people. Just a year ago, it was sitting at 1.4 million people. Now, stop and think for a minute. We only have 6.5 million people in the state of Arizona. And out of those 6.5 million people, only 3.5 million of them are working age adults between 18 and 65. We have a large segment of the population that's kids, they're going to school, and we have a very large retirement population in Arizona, folks that are retired after working and they're here to enjoy the sunset of their career in the beautiful weather here in southern Arizona. Well, they're out there, so you only have 3.5 million people in the system. So those 3.5 million people have to generate enough economic opportunity and what would then be taxes to be paid to the state to fund 1.5 million people. So you got literally, let's say, just short of 3 million people working to sustain these people on access. Access is a premier Cadillac plan. It is the envy of many states because it is one of the best providers of medicine. They pretty much approve everything except a few things. It's a very good health care plan if you're at the poverty level. We ran out of money from the tobacco settlement about 4 years ago. It was gone. The number of people that got into the system was far more than Janet Napolitano and anybody had ever predicted. Now, why did that happen? I'll give you an example. A lot of employers in the state of Arizona who were paying for health insurance for their employees and deducting money out of their employees' paychecks went to their employees and said, hey, look, here's the deal. I take $300 a week or every 2 weeks out of your paycheck, and I got this health care plan, and it's okay. But it's got high deductibles, it's got co-pays, and it doesn't provide all this coverage. The state has this really good plan that pretty much covers all this stuff that my health care plan doesn't, and I'll make you a deal as your employer. I will put that $300 every 2 weeks back in your paycheck if you drop out of my health insurance plan and then go apply for access. And a lot of hotels and restaurants and other businesses that had part-time employees made that option to their employees. And a swell of people that were previously insured by private companies left private insurance and immediately transferred over to the government plan. What Dr. Lee had kind of alluded to is the same thing is going to happen when this free stuff mentality affects everybody and they all figure out that they got this new free health care plan. All the employers are going to go, hey, look, why take money out of your paycheck? Why should I deduct whatever that amount is? I'll give you that little extra money in your paycheck. So that saves the employer money because then he doesn't have to pay the matching part of the premium. And the person sounds like it's a good deal. Hey, I'll take an extra couple $100 in my paycheck. And they're going to flood the federal health care system. The exchanges that are being set up around the country, except for a handful of states that have said they're not going to do it, basically have a subsidized health insurance plan in there where the government's going to pay part of the premium, and then based on your ability to pay and your income level, you're going to pay a portion of that. That's what the exchanges are set up for. Based on where you are at economically will be how much you're going to have to pay for an insurance premium for health and medical insurance. And these exchanges are going to be flooded by people that are going to be dropping off of these private plans and being transferred over. That's going to increase costs beyond what anybody predicted in Washington, D.C. I could tell you that already the Government Accounting Office and the Congressional Budget Office have, every year they revise the number of the financial impact of the federal health care law on the budget. When it first passed, as Dr. Lee had stated, they played a nifty little game of moving pots of money around to make it balanced, to prove and to convince everybody that it would actually save money and reduce the deficit. But what they did is they took revenue over a 10-year period, but then when they had the CBO, the Congressional Budget Office, score it, they only scored it for 6 years, but they used 10 years of money for 6 years of the program to make it balance. And those were even rosy projections, and that hasn't happened. So then the federal government realized that they're not going to be able to pay for all this, so they decided to shift it to the states because they can't afford it. So the big part of this federal law is the states have to ante up a significant amount of the money in order to fully implement the Federal Health Care Act. Now, where is the state going to get the money? Well, as you guys know, we just came out of the biggest financial crisis in Arizona history, a $3 billion budget deficit, and the state was literally 6 months out from bankruptcy. And many states are on that verge still today, but we're lucky enough that we've come out of it and our economy's starting to recover. If this goes into effect full bore, it's going to just drive us back into the financial ditch. The state's going to have to come up with significant amounts of money, up to $2 billion. It's going to start out, this is the way that the federal government did it. The first year, it's free, as they say, which means instead of taking the money out of your left pocket, which is your state wallet, they're going to take it out of your right pocket, which is your federal wallet. Like you have two separate wallets, everybody got the state wallet and when you pay, that's what the idea is. But they're telling the states that the first year of implementation, it doesn't cost the state anything. Set up the exchanges, expand Medicaid to the full 100, and well, actually, the federal plan expands Medicaid to 133% of the federal poverty level, not 100%. So it's even more. So once they do that, the first year, all these people flood the system. The states get used to that. The federal government gives the states enough money to cover all these people and get them in the system, and everybody's happy, right? Well, the next year, you don't get all, they scale it back a little bit to about 80%. And the next year, they scale it back a little more. And the next year, pretty much, they're only going to be paying for about half of it. And then the states are going to have to come up with the other half of the money. Well, where's the states going to get that other half of the money? They're going to get it really only in one place, from you. And they're going to get it any way you think you can possibly get it. In the end, we're all consumers in here. Okay? That's who pays the taxes. The consumer pays the taxes. And I tell people this all the time. They're like, oh, these corporations, we need to make the corporations pay taxes. You didn't pay attention in Econ 101. Okay? You go over here to Jim Click Ford, you buy a nice big Ford F-350 and it's white and it's got a 6-inch lift kit on it. And it's really big, right?
It's really big.
Yeah, you buy a truck over there and you're thinking, wow, that's a really nice truck. But it actually costs Ford half to build that truck of what you actually pay for it when you buy it. And they've got this. You can go actually look it up. I'm trying to remember the website that you can look up what a Ford Taurus costs to make versus what you pay for it. And then they show you that the differential is all of the taxes that it has to pay as that car goes through the system, whether it's the parts manufacturer and the taxes he's got to pay, and he adds that to the price of the parts, and then the shipper that moved those parts to the cars, to the Ford manufacturing plant, and then the employees there. I mean, it shows you. They actually have this breakdown. So usually cars are about half of what to build what you actually pay for them because of these taxes built in. So when I bought that truck, I paid Click's taxes because he's not going to pay it. So he builds that cost into the price of his product. Everything you buy has taxes built in. You don't even know you're paying it. It's a hidden tax. That is the secret of the federal tax code. Most people don't even realize what their true tax burden is because you're actually paying somebody else's taxes when you buy something from a particular company. They're not paying it. They shift it. They shift that to you. It's an overhead cost. That's how they do it. We are going to see a significant increase in inflation as a result of this because those employers, in order to implement those plans, will shift those costs into the price of their products. It will make this country less competitive. When you make the country less competitive, businesses start looking for someplace else to move their businesses. They move it to China. They go to Mexico. They go to India. Our economy will once again begin to go into a recession. So this is a significant impact. In the state of Arizona, we're estimating anywhere between $1 to $2 billion a year financial impact from the federal health care law starting in 2015. We don't have the money to pay for that. I don't know what we're going to do. My option is not to implement any part of the federal health care law in the state of Arizona and oppose it every step of the way. The exchanges, let me talk about that. You've been hearing a lot about the healthcare exchanges. The exchanges were set up so that insurance companies that meet certain criteria for coverage gain access to a pool of people looking for health insurance policies. Okay, so in order to get into the exchange, you have to meet, as an insurance company, certain qualifications. Now, those haven't been fully defined because they're still writing the particulars of the regulation, and Dr. Lee talked about the 13,000 pages at a cost already of $2 billion to write 13,000 pages of regulation. They're going to continue to write it. I have no idea what the final standards and criteria are going to be for access into the exchange. They've already listed some basic requirements that the insurance companies have to provide in order to gain access. But there are other insurance companies out there that sell sort of a tailored insurance plan that will not qualify for that plan. So if you have an HSA or an FSA in here right now, that's one of them. They do not provide detailed low-level coverage for everything you can think of. They provide high-risk insurance if you get hit by a bus, have a heart attack or stroke, and below a certain dollar amount, you pay for it with your HSA, with your credit card, or you pay cash. You have this high-risk insurance. That insurance does not qualify for the exchange. So when the president says, and this is funny, well, it's not funny, but when the president says, if you like your health insurance, don't worry, you get to keep it, that's true. That's actually true. But if you decide to change your policy in any way, shape, or form, you will not be able to do that unless you go to one of the healthcare exchanges and then have it go through the exchange to get a change. So if you're a young family and all of a sudden now you have a kid, now you got a change in your policy. Guess what? Your policy's no good no more. You can't have that policy no more. You got to go get a new policy, and you have to get it from the government through the healthcare exchange. So say you have Medicare supplemental insurance. Medical supplemental insurance is not sufficient enough to cover everything to gain access to the exchange. Unless that company already offers supplemental insurance, which some do. If the company that just does Medicare or supplemental insurance, they're done. They're out of business. Because under the law, they will not be able to sell any more policies. And they will only be able to maintain the policies that they have that go into effect in July of 2013. So July 1st, 2013, all those companies that don't qualify for the exchange, they just get to hang on as long, well, unfortunately, until their patients die. And as each year that less and less patients go, they get less and less money, which means they'll probably go out of business eventually because they don't qualify for the exchange. It is very anti-competitive. Only a handful of insurance companies will qualify for the exchange. And I submit to you that that was done by design. The insurance lobby, particularly here in the state of Arizona, is very powerful and very influential. I can just imagine what it is in Washington, D.C. I actually had a lobbyist from an insurance company in my office last year trying to convince me to support implementing the exchanges in Arizona. And I told him I was 100% against Inc. and Hep. I'm not going to support it. He was begging me. And then he had a moment where, everybody gives lobbyists a bad name, but this guy was honest. And he said, look, Mr. Antenori, I'm just going to tell you straight. We either go out of business in a couple years or we go out of business in 10 years. And the opinion of my employer is it's better off that we find a way to stay in business as long as we can. And the only way we can do that is to set up the exchanges. So it's either sooner or later, they knew, even the insurance companies know that the federal health care law is designed to push the country towards a single payer system. And they know they're going to eventually go out of business. When you compete against the government, you lose. The government gets to set the rules, and he who sets the rules wins. So these guys they know it. They look you in the eye and they go, we know that we don't have long to survive under our current business model. So our mission is to try to get as much money and make as much profit and survive for as long as we can until that day comes. And this only way to do that is to implement the exchanges. That's what these guys believe. And they're pushing for that. They talk about how many people that work for these industries are going to lose their jobs if this doesn't pass, and they try to scare people. I get emails from people that work for Blue Cross, for Aetna, for Aflac, all telling me that they're all going to be out of a job unless I implement the exchanges. And I disagree. If you read the Roberts decision specifically states that the federal government has no authority to mandate that the states spend money. They cannot force the state to spend money to implement the bill. It also states in there that if we don't, that they can't penalize us by withholding money. Okay, they can only withhold the money to implement that portion that we agree to implement. Or if we don't agree, they can withhold the money that we don't want to use. They cannot penalize the state. That is a significant portion of the Roberts ruling. In order to set up the exchanges, first of all, there's two phases. First, we have to expand the Medicaid population. In Arizona, that would add somewhere between 300 to 500,000 people immediately to the Medicaid rolls if we expanded it to the 133% that the federal government wants. That's a huge cost. Like I said, about $1 billion to the state initially, and then as more people get in the system, that number will rise. We can't afford it, so the state of Arizona will likely not expand the Medicaid population in the state. I mean, I think quite a few people in the legislature have already publicly come out and said they're opposed to expanding the Medicaid population. The governor hasn't quite said so. But on the exchange side, if we implement the exchanges, it's still going to cost the state of Arizona money to run the exchanges, to staff the exchanges. We have to pay for that. The federal government's not going to give us any money to run the exchanges. The state's got to do that. So under the Roberts decision, I would submit to you that we don't have to do it. We can opt out altogether. We have a State Department of Insurance. We insure dozens and dozens of insurance companies that provide all different types of health insurance and medical care insurance in the state, long-term care insurance, Medicare supplement insurance, HSAs, FSAs, full-blown coverage, tailored coverage. We have that. And we can continue down that road, and we can basically just say, nope, you know what, we're not going to do the exchanges. We're going to continue to allow insurance companies to function as they've been functioning in the state of Arizona and fight that battle. We will likely be sued by the federal government, but I think we have pretty good case law based on the Roberts decision to fight that battle back in the Supreme Court. The other side of the equation is just the freedom side of it. Last year, or the year before last, you, the voters, approved Prop 106. Prop 106 was called the Healthcare Freedom Act. It specifically stated that no government, state, county, city, federal, can get between you and your doctor with regards to healthcare decisions. This is the concept of our founding fathers, that you have a right to life, liberty, and the pursuit of happiness. Okay, and when the government intercedes on that key component, which is life, and interferes between you and a decision between either you and your family and your doctor, or just you and your doctor, or whatever, that is interfering on that fundamental principle in this country. And so we referred that to the ballot, and overwhelmingly, 60% of the people in this state said, yeah, I don't want the government interfering with the decision that should be between me and my physician. If you want to pay more for health care and get some special treatment that you want to get, or say something's experimental, and you're in a terminal situation where you think your life is probably, that some doctor said you're terminally ill, there's no hope unless you can try this experimental sort of thing right here, and then you go to the government plan and they say, well, we don't fund experimental. They already do that now. They'll tell you that we don't fund experimental therapies. You have no chance. You have no hope. Just go die. All right? But if you want, you can say, well, you know what, I'm going to take the chance. I'm likely going to die anyways. I want to take a hopeful shot at something new. Maybe I'll be lucky and I'll survive. Well, under the federal law, you wouldn't be able to do that. And we in the state believe you should have that right to make that decision. You should have the ability to expend, if you want, every dime you have to save your life. That's your decision. Who am I to judge whether, I could say, oh, that's stupid. You should just die and give that money to your grandkids. That's not my decision. That's your call. If you want to try to save your life or your spouse's wife or another family member, that's your decision. The government should have no say in that. But under this law, it does. I would submit that Arizona does not allow that. My argument is under the Healthcare Freedom Act approved by the voters, enshrined now in our state constitution, that we cannot implement the exchanges in the state of Arizona. It is unconstitutional under the state constitution to do so, because we deliberately would interfere with your discussion between you and your physician. I was a paramedic for 12 years, and I was also an Army medic. And when a paramedic or an Army medic, our oath, it's not quite the Hippocratic oath, but one of the key tenets of our oath is do no harm. Okay? That is first, do no harm. If you have a patient down there, everything you do should be there to improve the condition of the patient. So your mission is not to create more harm. I would submit to you that federal healthcare law does significantly more harm. If you look at the CBO projections that just came out last month, Paul Ryan's actually talking about this now on the campaign trail. The cost to fully implement the Obama healthcare law, including the addition of 31,000 federal employees. Now stop and think about that. They are going to hire 16,000 IRS agents who will now be auditing every company in this country to make sure they're complying with the law. They're going to be auditing the health insurance companies, and they're going to be auditing you. to make sure that if you don't have health insurance, you pay the extra tax for not having insurance under the federal health care law. Them 16,000 guys get full paychecks, they get pensions, they get medical, they get dental. You pay for that. Then they're going to add another, well, what was the math on that? So 16,000, 31,000, that's 17,000 more bureaucrats that are going to be handling all the tons of paperwork that are going to be generated by every hospital, every doctor that they have to fill out and send to get reimbursed, which will probably take a significant amount of time. And I guarantee you that you're not quite going to get back what it cost you, particularly for doctors. And that's why so many doctors are going to be leaving, because already the Medicare reimbursement rate is only about 60% of the cost of what it is to provide that care. By the time we're done, it'll be 50%, 40%, and there's no doc that's going to work for free. That's why Dr. Lee Vliet's saying it's like working as a slave, because they want you to work for peanuts. I got a pre-med degree. I almost went to med school, and then I took like Yogi Berra. I came to a fork in the road and I took it. So we're doing quotes. We're doing quotes tonight. So everybody makes decisions. So I got a pre-med degree. I got a bachelor in health science, minor in biology, and I was a paramedic for 12 years. I got an associate's degree in emergency medicine technology from University of Texas. So I have been out in the healthcare world for quite a long time. I have treated both with and without a license a lot of people for various illnesses. And I've seen the good side of the healthcare system, and I've seen the bad side. I've seen cases where people that abuse the system and take advantage of the system because it's free, whether it's that guy that calls on Christmas Eve and claims he has chest pain so he can go in the hospital and so he can get a nice meal on Christmas Day because he's in the hospital. I've seen that. You show up at the door with the ambulance and they got the suitcase packed, and they're ready to go, and they go, yeah, I got chest pain. I can't turn them away because of EMTALA. That's what Dr. Lee said. I got to put the guy in the ambulance. $700 just to walk through the back door of an ambulance in New York City. And then that's not counting all the other stuff that by the time we get to the hospital, it's probably $1,200. That's one of the most expensive taxi rides you can imagine. $1,200 for a ride to the hospital. Then he gets in the emergency room, and it's like $800 to walk through the doors of an emergency room. As soon as you walk in, it's $800. And then there's all the added stuff. They have to check him out. They got to do cardiac enzymes, EKG, all this stuff. Cha-ching, 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 cha-ching. So he gets put upstairs for observation, gets up in the morning, gets his nice little Christmas dinner, and then he goes home. I've seen that. I've seen people, who come in because they don't want to go to Walgreens and pay $10 for aspirin and Sudafed for a head cold. And they know that if they go to the emergency room, they get it for free. And they'd rather sit in the emergency room for 10 minutes so they get their free Sudafed and aspirin rather than take $10 out of their own pocket. But then they'll walk out of the emergency room, pull out a $5 pack of cigarettes, and light up a $5 pack of cigarettes and smoke their cigarettes. They got money to smoke, but they don't have money to take care of themselves. I've seen that. And then on the other side of the equation, I remember, and I told the story the other day, I'm in the emergency room, and we brought a guy in, and he had constipation. Everybody knew it. He knew it. He needed help. He said it's really bad. He tried taking a laxative, it wasn't working. He said, I need to see a doctor, something's wrong, I need something stronger. He knew what he had. We knew what he had. The emergency room physician knew what he had. But because of the protocols in that hospital, they had to do several tests on this guy to make sure he didn't have something else that would result in the hospital getting sued. So they did a full abdominal x-ray, they did a CAT scan, they did blood work on the guy, and guess what? He had constipation. So they gave him his nuclear level laxative and sent him out the door, and the guy was fine. But cha-ching, 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 those costs were all added up. The system gets abused on both sides. That's where the cost of delivery comes from. The legal side forces doctors to practice preventive medicine. There's the cost that they have to charge and add in their bill because of the insurance premiums. They pay for their own malpractice insurance. There's the cost that the hospitals have to cover for all this, and it adds up. So when Dr. Lee says that the problem isn't the access, it's the payment, she is 110% right. We could fix the health care plan in this country. We could have already now, they claim there are 45 million people without health insurance and 15 million that are uninsurable because of pre-existing conditions. We could have bought everybody right now with the $2 billion, we could have bought everybody insurance for a year. We could have just given it to them. And nobody's freedom would have been infringed upon. Nobody would have had all these IRS agents coming down and, checking every little nook and cranny of your financial records. None of that would have happened. And we could have given people insurance with the price we've paid so far. But instead, The government has decided that they want to set up a program that's going to affect everybody in the country, not just the 45 million. So the 300 million, well, we have 300 million, so let's just say minus 45. So we got 255 million people that are all covered under some sort of plan, Medicare or their private insurance or whatnot. We are going to basically take 5/6 of the country and impose on them something to help solve 1/6 of the problem. That's basically what this bill did. And to me, that just doesn't make sense. If most Americans, and the president admitted it himself, if you're happy with your health care plan, don't worry about it. You can keep what you have. He knows that the majority of Americans, if he said your health care plan was going to change under this law, he knows that it would have never passed. If he had told you that it was going to balloon the deficit and result in a huge tax increase, it never would have passed. If he'd have told you that it was going to result in an impact to the economy that was going to result in job loss and shift jobs overseas, it never would have passed. But they hid that from us, and now, as Nancy Pelosi so eloquently said, we have to pass it to find out what's in it. We are now finding out. And I can tell you, there's very little good in there. There's some good. The screenings for cancer, breast cancer, prostate cancer, they're claiming colon cancer. Okay, great. We could take care of that another way. We did not have to impose on the majority of the citizens in this country and in this state a significant impact financially and, more critically, to their freedom and their decisions between them and their doctor. We didn't have to do that. So we have to remove this problem. And there are some out there that would advocate that it can be fixed, that some good parts in it need to be kept. We need to tweak the rest. I submit we need to let's wipe the slate clean and have an honest discussion in this country about what we need to do to fix the system. We here in Arizona tried to do that last year. We tried to run a bill to allow you to purchase insurance from any other state in the country. So if you go to Idaho and Idaho's got a plan that's tailored for your needs and it's half of what it would cost in Arizona, you can buy your health insurance in Idaho. You can buy it in Texas. You can buy it wherever it is. This would create something crazy called competition. And when you do that, you watch prices go down. And I'll give you a perfect example. What is the differential between car insurance commercials on TV and health insurance commercials on TV? Just stop and think of that. Go home tonight and the next day or two, watch how many car insurance commercials you see. Why do you see the Progressive with that Flo chick and you got, the State Farm guy or the guy with the little funny duck feet on that has the cars all splash and crash and he does there's tons of car insurance commercials. Why is that? Because they are competing. You can buy car insurance from any company you want tailor your coverage. You want a $500 deductible, a $1,000 deductible. You can do that. You can tailor your car insurance to your needs. You got kids, you can add your kids to the premium. You can tell them which car they can and can't drive. I got 2 teenage boys driving right now. So I know. So you can do that, right? When you look at the concept of car insurance, let's think of it. And how much money, we are a car nation. How much money does the American consumer spend on their cars? The price to buy it, the insurance they pay in it, the gas they put into it, the tires, the oil, the maintenance that goes on. None of that is claimed on your insurance, is it? When you get a flat tire, you don't call State Farm, hey, I got a flat tire, send the ambulance, come change my tire, and I'll pay you $20. Here's my $20 deductible. You don't do that. You do it yourself. You pay it out of your pocket because you got insurance on your car. Nobody, because if we had to do that, you know what car insurance would cost? It would be ridiculous. Well, guess what? That's why our health insurance costs so much. Here we are, we're willing to understand the cost of providing maintenance for an automobile, but we can care less about the cost of maintenance for our own bodies. We're backwards, folks. We are truly backwards. We need to have the discussion, where does the insurance kick in? Should we pay, if I want to go to the doctor and get an exam and a checkup, should I be able to pay for that? I should. I could pay for that. It's maybe $100. Every 2 years you get an exam, $100. Why should I force the system to go in and have all these people fill out paperwork and turn that costs the state, the insurance company, the government tons of money. And in the end, it raises the cost of health insurance. We've got to be smart. We've got to get the ultimate regulator back in the driver's seat. And that regulator is you, the consumer. You are not in the driver's seat now. It is the insurance companies and it is the government that is driving the train. You need to take your power back, your influence back, and your freedom back. So with that, I'll end it there, and Dr. Lee and I will now be happy to entertain any questions of anyone in the audience. Yes, ma'am.